pillar of our coverage at the UN General Assembly. If you were with us last year, you might recall a bustling hall filled with side events and hundreds of global development and global health professionals. This year, we're recreating that experience, but we're doing it virtually. And like so much else that is happening in a different way in 2020, this will be a bit different, but I think you'll find it really engaging. And I'll talk to you a little bit later about what to expect today. Let me just say that this is the 75th anniversary of the General Assembly at the UN. And the UN General Assembly is something people have loved to love and to hate. Those of us who have braved the traffic and the crowded sidewalks and the long lines and security have sometimes wondered, what is the point of all this? Why do we do it? But in the end, the GA sets an agenda. It sets a narrative and a theme for the year. It relates to so many of the big issues that matter in the world, and it's a chance to lift those up and lift them up in front of really important audiences. And so we didn't want to miss this opportunity, even though it's virtual this year. And so Devex, working with a number of partners, is bringing you 3 days of this UHC pavilion, a focus on universal health coverage, an issue that was really brought to the fore last year at a high-level panel during the UN General Assembly. And that this year we're going to dig into much more deeply into many aspects of universal health coverage, many issues. Of course, many of them relate right back to the pandemic, but we're not going to stop there. We're going to get into much more depth on issues from maternal health to health worker safety and much more. So I want to thank all of you who are joining us. And I know we have participants from literally all over the world who are part of this, and a number of partners who I'll get into in a moment for being a part of it. This pandemic that we're all experiencing has, I think, shaken the way we see the issue of UHC. Certainly, it's affected the way I see it. We knew the statistics, and many of the people who are part of the session today live those statistics every day. The biggest one, perhaps, being that half of the world doesn't have access to essential medicine. It's kind of a shocking indictment in a year like 2020, when we can think about space travel and autonomous vehicles and tremendous technological advancement, that still for half the planet, basic healthcare is out of reach. And especially when we're facing a moment like a pandemic, when for each of us, for our own families, we think about how important it is to have access to that healthcare, and to think that people don't get that day to day all over the world is really shocking. And I hope that through the course of these 3 days, you will learn about both those challenges, but also the many opportunities to get this right. The many companies and nonprofits and international institutions and initiatives that are working to get this right. The world has started to focus in on global health in a new way, and hopefully has seen some of the promise, some of the new public-private partnerships and other endeavors that are working hard to bring vaccines and treatment and new opportunities to people around the world during this pandemic and beyond it. So we are delighted to do our small part in trying to leverage the Devex audience, the community that we built around the world of over 1 million global health and development professionals, to really bring these issues to the fore and to learn a lot more ourselves. You're going to get to see and hear from Devex journalists who are all over the world, something that may have been more of a challenge in previous General Assemblies, but because we're virtual, the upside is you're going to have many more voices from all over the world today, sharing with you, I think, really unique perspectives. So in a few moments, we're going to get started, but I wanted to say just a couple of things before we did. The first is, if you have been a part of Devex events like this in the past, you know that so much of the magic comes through partnership. We couldn't do this without incredible partners, and that's both because they provide financial support in some cases, but also their expertise and leadership on a lot of these issues. And you're going to see that woven through these days of the UHC Pavilion. I want to particularly mention our partners for today: BD, MSD for Mothers. Many of you in the US know them as Merck for Mothers, and Smile Train. You're going to be hearing more from them during the course of the day. And through the 3 days of the UHC Pavilion, you'll be hearing from other partners like Seed, Takeda, World Vision, Plan International, the Japanese Organization for International Cooperation in Family Planning, United for Global Mental Health, AstraZeneca, Digital Connected Care Coalition, and Transform Health, among many other groups that will be part of this. But I want to give a big thank you to these partners and sponsors. If we were in person, there would be loud applause for all of you, and I'm sure there will be at homes and living rooms all across the world right now. Thank you again for being a part of this. We're going to begin in a moment, but before we do that, I just want to mention that we're using a platform called Hopin this year. It's a virtual platform. If you're not on it, if you're not sure what to do, go to the Devex social media channels and we'll provide a link there. So, follow us on Twitter or Facebook or LinkedIn. Go to Devex and follow information there. You'll also have a chance, if you'd like to follow Devex reporters and editors throughout the day that you see, you can follow me on Twitter, and we'll be posting information about what's happening during the course of the day. There's also a website that I'd recommend to you that we've launched for the General Assembly this year. It's unga75.devex.com, unga75.devex.com. We've launched this. It's got news, it's got events, it's got some really interesting breaking stories about what's happening in UNGA this year, interesting perspectives. It's even got a special section on social entrepreneurs, which is being brought to you in partnership with the Skoll Foundation. So a lot of really interesting content there that I recommend to you to check out. If you get lost at any point in the day, that's a good place to go to reorient yourself. And then finally, if you want to join the conversation online, and we really want you to, use the hashtag UHC Pavilion and just tell people what you're thinking, what you're hearing, add your own insights. There are lots of opportunities today to answer poll questions and to submit your own questions to the conversation. I want to ask my colleague to join now because we're going to tell you about the first of our segments today, which is called Safety First. So is Jenny Lee Ravello there out there in the ether? Please turn on your video and join me here.
Hi, Raj.
Hey, Jenny.
Good morning. Hi. Thank you so much.
Nice to see you. Nice to see you. So Jenny, you're coming to us from your home in Manila.
Yes, I am.
And Jenny, as our audience knows well, is a senior reporter at Devex that covers global health. People read your byline very carefully. You cover the WHO and so many other issues related to this pandemic and beyond. How are you doing today?
I'm doing well. Very excited, actually, to kick off our UHC Pavilion series, especially because we are focusing on a particularly important topic, which is healthcare worker safety. In our many conversations, we've talked about how health workers today are regarded as heroes, and they are really in every parts of the world. But as modern day heroes also need the tools to make sure that they are safe in carrying out their work. And unfortunately, and it's very heartbreaking and frustrating to see how many of our health workers have been infected with COVID today.
Yep.
Some of them getting really sick, some having lost their lives. But
it's easy to say they're heroes, but then it was such a fight to get basic PPE, and including for community healthcare workers. And it's still not easy all over the world to get the PPE. And as you say, many healthcare workers face the brunt of that. And so we're going to dive into a session this morning that is really focused on this issue. And actually, it brings up some points that I was not aware of and until I started to dig into this series, Safety First, that Devex has been covering for some time in partnership with BD, which is a leading medical technology company. And one of the key data points for me was this idea that every year, some 3 million healthcare workers get an accidental needle prick. And obviously can be dangerous, can cause them to get sick, but maybe there's stigma around it. And so they don't want to tell everybody. Maybe they're put in these tough environments where they're working so hard, so rapidly during the course of the day, they get a finger prick and they just don't want to stop and they keep going. But healthcare workers have to take care of themselves, and we have to make sure they have the tools to do that.
That's true. And actually, you mentioned about 3 million, which I think really perhaps is underreported, really. So there may actually be more than what is known today. So I'm really excited to be talking about this. As you mentioned, Devex has an ongoing series on the topic of health worker safety with BD, with a focus on needlestick injury. And we're all very fortunate today to have an excellent set of speakers and panelists who've years, or some of them actually have decades of experience tackling this issue on the front lines, and really looking forward to understanding the challenges, but also what are the tools that we have today to keep our health workers safe. What are the best practices and successes that we've achieved? So really looking forward to that. Just a couple of things to note. Again, this is the first event in the series that we're launching. please remember hashtag UHC Pavilion. And so for the next 3 days, we'll have more health events coming up. So please sign up if you haven't. But I wanted to kick off this discussion, and thank you, Raj, for helping
and
introduce
thank you.
this.
I'm gonna turn off my video because I want to watch this conversation, and I'll be back as we continue the UHC Pavilion during the course of the day. You're going to get to hear my interview with the Secretary General, Antonio Guterres, right after this session. And then we have another session about maternal health that you're going to want to stay tuned into. So we've got hours of really fascinating conversation on global health to come to you today, and really excited to hear your panel.
Thank you. Okay. I want to kick off this discussion, actually, before we go into the nitty-gritty, by asking Gary Cohen. Gary, can you please turn on your video? Executive Vice President of Global Health at BD. And also, Gary is also the president of the BD Foundation and a member of the BD Executive Leadership. So, Gary, you've been at the forefront of tackling health workers' safety issues. Can you give us a bit of an insight as to how important is this really? And what are you looking forward most to in our discussion today?
Well, thank you, Jenny. And thank you, Raj. We really appreciate the opportunity to highlight this issue during such an important week. You know, the bottom line is health workers should not have to put their own lives at risk to save the lives of others. Each health worker is precious. And at times like the Ebola outbreak in West Africa in 2014, or now with COVID-19, this kind of comes to the forefront. Though health workers put their lives at risk every day in their routine jobs because the work environment for healthcare is risky compared to most other work environments. Now, I'm one of those people who goes back decades on this issue. I actually started the healthcare workers safety focus at BD back in the 1980s. And that was really triggered by HIV and AIDS when two health workers seroconverted. They got HIV from a sharp object injury, one in Africa, one in the US, back at that time. And in parallel, WHO and UNICEF were concerned about spread of HIV and hepatitis through mass immunization of children due to device reuse. Both of those issues were of concern around the same time in the mid to late 1980s. And there was a response very quickly on the technical side. The first safety needle was introduced in 1987, the first safety syringe, which was from BD in 1988. The first auto-disabled syringe to prevent reuse came from BD as well, went into WHO field trials in 1988. One thing we realized early on, we thought there would be fast uptake of these devices, and there wasn't. At the time, hospital administrators did not consider this to be an issue that was a priority. So we made substantial investment in education and training, working with professional organizations, and also in surveillance, the EpiNet system, which is used in nearly 90 countries around the world now, and is available at no charge in those countries as a surveillance system for needle stick injuries. And there was strong cooperation from the outset across sectors and across stakeholder groups to advance this forward. That was also reflected in progress made on policy. The first policy action in this area was 1999, a joint policy statement on immunization safety from the World Health Organization and UNICEF. The first national law to protect health workers from injury, needle stick injury, was passed in November 2000. It went through our Congress with no opposition. That doesn't really happen much any longer. I had the privilege of standing behind President Clinton when he signed that bill into law. There were additional policies in Taiwan and Uganda, Brazil, but just a handful of countries. Then the European Union had an EU-wide directive similar to the US law that they put into place in 2010. In 2015, WHO issued its safety injection policy. So these were key areas of progress to get transition up to higher levels, though enforcement varies. And you need more than policy. You also need those policies to be enforced. So I would say a lot of progress has been made, but there's still so much to be done. In the areas of progress, there's been billions of dollars of investment in the design and manufacturing of needle stick protection and auto-disabled devices. There's been near elimination of reuse in mass childhood immunization programs. There's been over 6 billion immunizations administered safely with devices that cannot be reused since 1999, since that policy was passed. There's been widespread transition to needle stick protection devices in hospitals in the US and in Western Europe, and to a lesser extent in other industrialized countries. And of course, because of that, there's been substantial reductions to health workers in those hospitals, though that progress has leveled out to some degree in recent years. On the negative side, well, there's mass inequity here. Limited access to needle stick protection devices in low middle income countries, wide gaps in policy and access. And, Devex will be issuing a report that calls needed attention to that problem. There's also continued use of conventional devices without protection features, even in the US, outside of hospitals, because of lack of enforcement in those settings. Blood drawing, which is one of the most dangerous things you can do with a syringe and needle, continues to be done that way. We've been engaging for years with PEPFAR on training on procedures to draw blood safely. And there's insufficient prioritization in general in protecting health workers. Keep in mind, most are women, so this is also a gender-related issue. So just looking forward, some challenges to overcome. We've got to vaccinate the world's population against COVID-19 and do so safely. We've got to embed needle stick protection into the personal protective equipment mindset, deploy auto-disable devices where they're needed to prevent reuse, and also think about the environment and how those devices that are going to be used for COVID-19 will be disposed of safely to protect health workers and the community. So Jenny, I think I'll stop there, and I appreciate the opportunity to speak this morning.
Thank you very much, Gary. Really, some powerful message there. Each health worker is precious, but also, the slow uptake of some of these safety devices really we'll go deeper into those issues later on with our panelists. I just want to emphasize again that we're hosting in this event in partnership with BD, and you can follow our conversations here, but also on social media. Please tag us, use the hashtags safety first, use the hashtag UNGA75, and keep us in the loop in your conversations. Again, there will also be Q&As later on during the panel, so please send in your questions. And there will also be a poll, actually. So I encourage our audience really to participate, and we'll be reading that poll later on during the event. We also have a live illustrator, Jack Broom. He will be, so you'll be seeing some really interesting points throughout, not just our faces throughout the discussion. So lots of things to look forward to. But first off, let me direct you for a few minutes to a video of a nurse who've experienced firsthand the dangers of needle stick injury and who've become a champion and vocal advocate of needle stick safety. Please watch.
My name is Karen Daley. I'm a nurse. I've been a nurse for over 40 years. I was a nurse at the Brigham and Women's for almost 26 years and worked the last 22 of that clinical care period in the emergency department. One weekend while I was drawing blood on a patient, I went to stick the needle that I drew the blood with in a box behind me on the wall and was stuck by another needle that was sticking out of the box. After the needle punctured my index finger, there was blood on the outside of my gloves. I took my glove off and there was a bruise on my finger, so I knew right away that it was a deep puncture. One of the first things I thought is, oh God, now I'm going to have to come in on my day off to be seen for this. It was such a common occurrence in healthcare at the time. It was my 5th or 6th needle stick. Luckily, the nurse who had asked me to come draw the blood was in the cubicle with me. She almost read my mind. I always think about her when I tell this story. She turned to me and she said, I know you're going to report that. And I always think of her with gratitude because I'm not sure that I would have. I was seen by the nurse practitioner in the urgent care clinic. She went through the protocol and she offered me the PEP, the prophylaxis for HIV. And I thought, what's the likelihood that the person whose blood was drawn with that particular needle had HIV or hepatitis C? I just didn't think the risk to me was substantial enough to take these drugs. Because of that assessment, I didn't take the prophylaxis that was offered to me, and now I live with HIV. it's really important for all of us to take care of each other. In my case, it was the right thing to report. I never could have afforded the care that I've required over time. More than $1 million without even being hospitalized once. Without a clear sense of how many of these injuries are occurring, we won't know if what we're doing makes sense or makes a difference. It's really important to understand that worker safety is patient safety. That if you're protecting the day-to-day safety of the workers providing the care, you're protecting the patients. And to separate the two doesn't make fiscal sense, and it certainly doesn't make sense from the standpoint of our basic mission as healthcare providers.
Worker safety is patient safety, and how these two are actually inseparable. I hope that you're able to catch that, because I think we're going to have a lot of discussions on this issue today. Devex is, together with BD, is launching a report on this topic today, and I'd like to introduce my co-moderator and lead of the report, Pete Troila, to discuss some of the report's takeaways. Pete?
Thank you, Jenny. What a powerful and impressive personal story. We are going to welcome Karen Daley, who was featured in that video, to join us shortly, so you can hear more about her story and learn from her experience. Very important feature of our event today. But first, as Jenny alluded to, I'd like to introduce the findings from a special survey and report Devex produced in collaboration and partnership with BD. It's part of our Safety First content series, and it features unique perceptions and recommendations from healthcare workers on this very important topic of needle stick injuries. So for those not too familiar with Devex, one of the most important resources we have is our network of development and health professionals. So we can tap into that network and gain insights into what is actually happening on the ground. And for this report, we accessed that network and conducted an online survey of more than 1,000 healthcare professionals from more than 100 countries around the world. These are doctors, nurses, health administrators, community health workers, and other occupations. And then to supplement that survey and gather firsthand and more nuanced insights, we spoke to 14 healthcare policy leaders and practitioners with experience in sharp safety. So one thing I really want to emphasize is how much we respect and appreciate that many of these folks are so deeply engaged in the COVID-19 fight, and they still dedicated their time and attention to this project. So our sincere thanks for that. Next slide. So here is a summary of our key findings. And I'm going to go into each one of these specifically. Next slide, please, Emily. So here's what we found out. The first is needle stick and other sharps related injuries are still all too common among healthcare workers. That's what we're here to discuss today. It's a serious problem, but not many people are aware of the problem really outside of the medical field. So in our survey, 65% of survey respondents have sustained or know someone who has sustained a needle stick injury. Among nurses, that number is actually higher. It jumps to 75%. Our respondents told us that the top events causing these injuries are recapping needles, taking blood, using solid sharps, disposing needles, handling rubbish, injecting an IV or catheter, administering injection, and activating a safety feature. All, as you can tell, very common procedures. Next slide, please. And healthcare workers in low resource settings and low and middle income countries are especially vulnerable to these injuries. And the WHO estimates about 90% of them occur in low and middle income countries, even though that data is lacking, something we will discuss. From our survey, 71% of the respondents in sub-Saharan Africa have sustained or know someone who's sustained a needle stick injury. In contrast, only 60% of our European respondents. And as you can see there from the quote, from Florence West of the International Confederation of Midwives, suggesting that in many low resource settings, medical staff are simply overwhelmed, they're rushed, they're under stress, and at times even forced to reuse and recap needles, increasing their risk of exposure and vulnerability. Next slide, please. And as Gary mentioned in his opening comments, I mean, COVID-19 has shined a spotlight on risk awareness and healthcare worker safety. So while these issues have always been important, the current pandemic has really drawn some urgency of protecting healthcare workers in a way that maybe the common public was not aware of before. Well over 90% of our respondents agree that the pandemic has increased awareness of these issues, and more than 80% agree that in addition to issues like PPE, other protection measures, including needle stick and sharps injury prevention, have improved in their workplace since the onset of the pandemic. And there'll be more on this, I think, during our panel session coming up. Next slide, please. The report also highlights that access to safety devices and training must be improved, particularly in low and middle income countries. The report defines and explains several important safety engineered sharps devices with built-in safety features or mechanisms that reduce the risk of exposure. Time and time again, our in-depth interviewees stress just how important these devices are to health worker safety. Meanwhile, 85% of survey respondents said establishing clear policies and training programs is the most effective way to address needle stick injuries. And I believe our panel session will also dig into safety devices and training as well. Next slide, please. As the video profile of Karen also highlighted, our report underscores that underreporting and stigma really hurt efforts to improve health worker safety. We identified the top reasons why a needle stick or sharps injury was not reported, including that health workers are simply unaware of how to do it, of the reporting protocols. Also, around half of the respondents believe there's a stigma attached to the reporting. I think we'll probably talk a little bit more about that. And you see the quote there from Dr. Dott, of the Executive Director of Women in Health, that healthcare workers sometimes fear that if they report the injury, they may lose their jobs. That's their very livelihood, and obviously a huge cause for concern. So how do we get over this? The report concludes that healthcare facilities should really establish clear and accessible reporting mechanisms for workers. And I think Karen's going to give us a much better understanding of some of the reporting challenges and opportunities that are out there. Next slide, please. And as Gary got into a little bit, enforcing safety policies and effective legislation can advance sharp safety. This is certainly something I want to discuss with Karen. Really, only a few high-income economies such as the US, Canada, Australia, Taiwan, the United Kingdom have specific government legislation, and the European Union have specific government legislation to prevent and manage sharps injuries. And our survey shows that while 71% of respondents believe current legislation, regulations, standards, policies are effective, only 40% they are not effectively enforced. So that enforcement really appears to be really a very key issue in all this. Next slide, please. So that is a overview of the findings that we're going to dive much deeper into. Thank you very much for your attention. I hope that was helpful to frame some of the issues we'll discuss throughout the remainder of the program. Please do download the full report. I really believe you'll find it interesting at safetyfirst.devex.com. And now I would like to bring Karen Daley into the discussion. Karen, welcome, and thank you for joining us. This time, still virtual, but very much live for our audience. Welcome, Karen. Karen, do you copy? Just give Karen a second to reconnect here.
Hi, Pete.
Hi.
I just want to, while we wait for Karen, I just want to ask our audience. So we have a poll, and I wanted for you to please vote and participate. The first poll that we have is, what is the biggest threat to healthcare worker safety? So is it exposure to hazards such as needle sticks and hazardous drugs, a lack of PPE and safely engineered devices, or a lack of funding for health systems and preparedness? We'll be pulling up the results later today, but please let us know what's on your mind. And while we wait, I think we have Jack illustrating for us. So okay, I think we still don't have Karen. I think we will be. Let's jump to our panel discussion, so we don't lose a lot of time. Thank you, Pete, for giving us a sense of the highlights of the report, really, and so many interesting points there. We'll build on that discussion, and we have an excellent lineup of panelists today. We have Dr. Amber Mitchell, President and Executive Director of the International Safety Center. Her career has been focused on public health and occupational safety, and she has received several awards for her work on healthcare worker safety, but also on bioterrorism and public preparedness. Karen, can you please turn on your camera? We also have on our panel Dr. Sanjeev Singh, who is currently medical superintendent in the Department of School of Medicine, Amrita Institute of Medical Sciences and Research Center in India. It's one of the largest medical facilities in the country. We also have Laureen Plummer. So Laureen is a clinical educator for systemic therapy at the London Health Sciences Center in Ontario, Canada. She's a certified oncology nurse and has over 27 years of experience in oncology and hematology. Last but not the least, we have Dr. Daniel Kimani, a public health specialist at the U.S. Centers for Disease Control and Prevention, Division of Global HIV and TB, based in Nairobi, Kenya. So everyone, please turn on your videos. Welcome and thank you for joining us today. I just want to get a sense from our producer. Can we pull up the results of the first poll that we have before we start our panel? Let's just give him like 30 seconds, please. Any minute now, I think. Let's just wait. Okay, so the results are in. So the question was, what should be done to better protect healthcare workers? So 38% said more training programs on the prevention and management of workplace safety. 29% more awareness around safety issues. And 33% said better access to protective gear and devices. So really, there's a varied responses from our audience today. Thank you very much for participating. We'll have another poll later on, but first I wanted to kick off our panel. Really, the report talked really some interesting points in there, but I wanted to ask Amber. Amber, can you tell us a little bit, because the report, there's a lot of data really in there, which is really good, but you could talk us a little bit how powerful data is in tackling healthcare workers' safety, and how is this being utilized today to reduce these hazards, these injuries?
Sure. Thank you so much first for the invitation. It's such an honor to participate. And I think in light of the current pandemic, it will be interesting to see what data looks like now compared to in the past, as there are more procedures being done that can easily result in more injuries occurring. Prior to COVID, though, we only know how prevalent injuries are and exposures if we measure them. This is the critical importance of needle stick and sharps injury incident surveillance. And really, we can only address and work to prevent what we measure. And as Gary mentioned, our incident surveillance system is called EpiNet, and it's been used as a benchmark for comparing injuries since the mid-1990s. We know from EpiNet, again, as Gary mentioned, that there have been drastic reductions in injuries from blood collection and IV catheters due to the advancements in sharps injury prevention or safety device uptake and use. Unfortunately, unlike the Devex data, ours is very different. That the data that was presented by Pete, we're still seeing the largest numbers of injuries from disposable syringes. Those are mostly used for insulin and vaccine delivery. And this is something that we really have to keep in mind as mass distribution of injection devices occurs when there is a COVID vaccine. This means careful attention to safe injection practices, using devices with sharps injury prevention and reuse prevention features built in, safe disposal, and really increased mindfulness on safe and effective training. So having those systems in place that measure injuries and therefore can measure successes that occur when these elements are utilized is how we illustrate the real impact of public health interventions. And as Karen mentioned in her video, this is thinking not just about patient safety, but how health worker safety improves overall outcomes and the well-being across the globe.
I wanted to follow up on that because in the report, Pete said one of the things that was mentioned was health workers don't always report the injuries, and some feel that if they report they may lose their jobs. So how do you, I suppose, marry the two in terms of we need to make sure, we need to have a robust surveillance system in place, we need to know what's happening so we're able to prevent this, but when they don't report, what happens?
Well, first, that fear needs to dissipate. And I think that is in improving the overall culture of safety in any facility. And this would be true for a needle stick, a sharp object injury, a back injury, a slip, trip, or fall. I mean, really any injury, because the only way to improve overall healthcare is to be mindful of the wellness of our health workers. I think one of the ways to improve reporting is first for people to know where to go. So a lot of times if they're out in the community doing vaccination programs, they may wait or forget or not know exactly where to report. Having instantaneous surveillance systems are a good way to do it. Our data is also presented confidentially, so there are no employee demographics associated with the data. Clearly, the occupational health or infection prevention nurse or employee health nurse is going to know who that employee is. But then those records are kept confidential. and that information is not shared with anybody, including the employer. So in the United States and in several other countries, we actually have requirements in place that are federal regulations that say that the employer is not able to have information about the status of their employees. They may just know that they had a Sharps injury, but they wouldn't know or have access to any of the other medical information. So confidentiality, I think, is a big means to increase reporting.
I wanted to build on that. I wanted to ask, how's that coming along on the ground? Dr. Sanjeev Singh, can you tell us a little bit about, what are the most common health worker injuries or hazard exposures happening at your hospital in India? And can you tell us a bit about what policies are in place to first, to help healthcare workers to report when they're exposed to this things, but also what policies in place to make sure that health workers have the safe environment and have the tools in place to keep them safe from from injuries.
Thank you, Jenny, for that question, and I really appreciate the opportunity which has been given. And I would acknowledge that almost a decade back, we visited the International Safety Center, and we are very grateful to BD and Janine and the whole team for giving us those insights which is required for healthcare worker safety. And as you rightly said, patient safety has that kind of an impact overall in the healthcare setting, but somehow the healthcare worker safety also needs to be at that level. So in India, there are close to 80,000 hospitals across the country, and there are 681 centers only which are accredited. And these accredited hospitals do collect that data. And out of those accredited hospitals, there are 48,200 needle stick injuries which happens, and close to 1,200 blood body fluid exposures which happen. So if we estimate, this could be at least 5 times the number, and that is astronomical. So what we see is low reporting. The low reporting is because there is no surveillance, there is no data capturing, there is no systematic, structured response which has been generated across the country. And it's just an islands of good hospitals where this data exists, and some of the educational activity which exists. To your question that what we need to do, I think it will be multimodal, because none of the single strategies are going to work. I think a very strong surveillance system, somewhere mandatory surveillance system is going to work, because we realize wherever it had been legally impactful, like just biomedical waste management system within the country, the adherence is or the compliance is much better. So a very structured, good surveillance system is going to work. Funding, I thought that in your poll they will also talk about funding being a major factor. It is in a low middle income countries, because the healthcare delivery is pretty cheap. So on an average, a bill for a length of stay of 4, the average patient would be spending close to $625 only, and which could be possibly 8 to 10 times in US. But if you look at needle stick injury, if there is a needle stick injury, and if you go ahead with your investigations and immunoglobulin, that is just $30 for each institution. So which is not much, and vis-a-vis incorporation of safety devices or sharp injury protection devices or reuse protection devices. So I think funding is important. Monitoring mechanism is not in place. So I think that both in public and private. So we have tried in a very small setting, and I think BD really helped us in and then building a curriculum across the country. Somehow the nursing staff, from out of 28 states, Kerala is a very small state, and we have 200 nursing colleges in just one state, and there are 28 of them. and plus 9 union territories. So attrition among the nursing staff is very high. So by the time you train people, you do an induction training, you do an in-service training, 11th month they are. So you are always retaining, and I firmly believe just training is not going to help. So there needs to be an equal auditing, there needs to be a behavioral change, which will also work.
Dr. Kimani, you're on mute.
So they are highly overworked, and the nursing patient ratio in many of the public setting hospitals is one nurse to 40 beds. So in complying to good standard practices is very poor. Many of the nursing staff still believe that the standard precaution is barrier nursing, good hand hygiene and PPE. The safety of safe injection practices, safe infusion practices doesn't exist. And then there is this gap between the knowledge and the action which goes. So there is a lot of work which needs to be done. There is some work which has been initiated through accredited institutions, through consortiums, through help across the sectors, through BD. But I think there is a lot more needs to be done, and at least to get a good policy, good advocacy towards the safety engineered devices.
Thank you so much, Sanjeev. I want to turn to Daniel. Daniel, are you seeing a similar pattern, similar situation in Kenya in terms of the scale of the problem? You know, earlier Pete mentioned 71% of the respondents to the report said that in sub-Saharan Africa, 71% of respondents, there's a high number that have sustained needle stick injury. I wanted to understand a bit more the scale of the challenge in Kenya. And do you have, you know, perhaps better policies in place, or are you seeing similar challenges and more needs to be done in there?
Yeah, thank you very much, Jenny, and thank you for this opportunity. Our situation is very close to what Dr. Singh has actually described. First, stating that one of the problems we have in low and middle income countries is the healthcare worker to patient ratio is quite suboptimal. What that means is that once you have a healthcare worker who is exposed, a lot of patients actually are missing services. The second thing to mention is that the prevalence of bloodborne pathogens, HIV, hepatitis, and others are actually higher in our settings. And therefore, it means that one needle stick injury can pose a double risk or even more risk of infection. But thirdly, to confirm that needle stick injuries are quite common in our settings, we actually don't know the magnitude because of the underreporting, but we suspect that every year between 2 to 4 in 10 out of 10 healthcare workers actually get a needle stick injury. But what I want to mention is on the positive side, really try to say, what are we doing as a country to address this? I think I want to look at it in different perspectives. First of all is the issue of policy and guidance document. I know Pete did show that a lot of this is implemented, but I think is a great step to actually have one in place. So in Kenya, we have a general infection prevention and control policy and a guideline document from the year 2015, but we have a more specific injection safety policy, which was adopted from the WHO policy guidance of 2015. So that document is fairly recent and actually recommends some of the issues we are talking about, for example, adoption of safety engineered devices. Secondly, in terms of human capacity development and training, we've been lucky to have several initiatives, mostly supported by the President's Emergency Plan for AIDS Relief. Initially, one was called Making Injections Safer, and this saw over 25,000 healthcare workers trained on injection safety. Later, we had a program addressing healthcare waste management, and another project that was a partnership with BD that was addressing safety of phlebotomy and blood collection. The third point I want to say is that the surveillance system and the use of data. we have a national system. It may be rudimentary, but it is able to get data from all over the country, very close to what Amber mentioned about EpiNet. And what we have done is actually to be a bit innovative and use the mobile phone, a simple application that the healthcare worker can actually use. And what that has done is actually to provide us with two things. One, it provides the privacy and confidentiality such that the healthcare worker doesn't have to record this in a book that can be accessed by others, but it actually provides us with the real-time data that any person getting injured, you can get end-month summaries. But beyond having a surveillance system, I think one bold step we took is actually to utilize that data. We took data and analyzed it to understand our situation, who is getting injured, what is causing the injury, and what procedure. And unbeknown to us before, we had concentrated on IM injections and blood collection. We actually realized that the issue of infusion safety, that is IV cannulation and the like, was actually the second leading cause of injuries in our country. And we have gone out of our way to actually have a program, again, a partnership with the BD, the Ministry of Health, and the CDC to address the issue of infusion safety so that we can reduce the needlestick injury. The last 2 points I want to mention is related to devices. We are increasingly having a safety engineered device, both for blood collection and medical injections, but also having other commodities, PPE, and availability of post-exposure prophylaxis drugs, so that in case one gets pricked, they can actually get a preventive measure. And finally, the issue of risk communication and raising awareness. We know this is a big issue in our settings. One of the reasons we have so many injections in Africa and in our country is because patients prefer to get an injection. They believe an injection is stronger, it is faster, and therefore they demand for it. And that makes healthcare workers sometimes to give it unnecessarily. So we have had campaigns to try and raise awareness that sometimes a tablet can be as good as an injection. But beyond that, we have also tried to keep the conversation about needlesticks alive. Just last week, we had the World Patient Safety Day. And in our country, we were marking this with a heightened realization of the exposures due to COVID. But we actually took advantage of that day to again discuss about needlestick injury. So for me, this is exciting having this session just soon after that. So thank you very much.
Thank you, Danielle. I want to turn over to Laureen. Laureen, so having the tools is important. Making sure that healthcare workers are aware of the dangers and have the proper training, to keep themselves safe is equally important. And we've heard that from our audience earlier about asking for more awareness, trainings. What's the biggest challenge, in training nurses, especially when it comes to cancer therapy? Exposure to hazardous drugs, and what have you learned? Or some of the lessons that you can share to enforce, uptake of this safety protocols?
Yes, hi, thanks. I want to kind of harken back to what Dr. Singh had mentioned about having lots and lots of education out there for the staff, and you can continue to give that education, but actually getting the staff to take that on board, to implement the change is really hard to do. Change for any of us is really hard. And so you can have all the PPE and all of the safety devices available, but if they don't actually value that or don't feel that it's going to give them some kind of personal benefit from it, they're not going to take it on board. So you really have to ensure that the staff are buying into that. One way you can do that is making it personal to them. And I think, a lot of the discussion today has been about needlestick injuries, and it's pretty easy to point to the sharp end and say that's your risk. With hazardous drugs, it's a little more insidious because you don't know when you've been exposed. You don't know how long after that exposure you may or may not develop symptoms or secondary disease because of it. And so in my history, I have really suggested having surface testing being done in the actual location where we're trying to implement the change, so that people can see that, in fact, there are hazardous drugs around them, even if you can't see it or touch it. It is actually there. And by making it a little bit more personal, it brings it more into the front line. Additionally, having peer supports is really important. It's one thing to have your boss tell you to do something because it's good for you, and it's another thing to have your coworkers be the voice of reason and really be the ones that are championing the implementation of that PPE wearing or the safety devices. We definitely want to encourage safety engineered devices, and in the hazardous drug world, we really look at closed transfer devices as being the gold standard, but we know that that's an expensive option, but an excellent option to put into place, so that if PPE is missed or is mishandled or whatever, then your risk of exposure is going to go slightly down for sure. It's really a multi-factored approach at it. So, getting your peers, getting that education out there continuously, because as Dr. Singh said, nursing is a constantly changing program. Nursing staff need to be reminded regularly, and that goes with education. But if all else fails, sometimes it has to be punitive, and the workplace has to say, you must wear it, or there's going to be consequences for it.
Thank you so much, Laureen. We're going to jump now to some of the questions. We're getting questions from our audience. The first one is, stigma and fear of discrimination is one of the key reasons why there is an underreporting of needle stick injuries. How can we begin to address this in all care settings? Anyone? Perhaps Dr. Amber, Daniel?
Amber, did you see both of us?
Yeah. Well, I think one of the ways to get around fear and stigma of reporting, again, is partially what Dr. Kamani mentioned. It's the confidentiality of the reporting system. So building the system to improve reporting because that worker's information is kept confidential. I think another thing too is as there's more uptake with devices with Sharp's injury prevention features and less injuries occurring, there will by default be less reporting because there will be less injuries occurring. But that was actually one of my questions for Dr. Singh and Dr. Kamani is improving reporting is one thing, but what do you think motivates a facility to have robust surveillance in place that maintains confidentiality versus one that doesn't? So that motivation of the facility is also going to improve the culture of safety and improve reporting.
Yeah, so one of the things that I've seen work and being a motivation is actually to use the data that you have to actually improve. So when healthcare workers understand that this reporting will contribute to a report that will be utilized to improve the safety, that alone actually improves. But the second thing is having leadership buy-in. For example, the head of a facility, if they show interest and commitment to improve the safety of healthcare workers based on the data, I think that again is a motivation. Coming back to the issue of stigma and how that can be reduced, also knowing that there is a care and treatment, for example, availability of the post-exposure prophylaxis, one knows that there is a good possibility that you'll be protected. But secondly, we've been encouraging in our region people to know their status. One of the stigma related to HIV is because one of the prerequisites for you to get complete package of post-exposure prophylaxis is that you have to undergo a HIV test. So if some healthcare workers already know their status, then they don't need to go for it. So we have these self-testing kits that are now available, and we actually see healthcare workers are taking these so that they already know their status, and that gives them confidence. Thank you.
We also have one question. How do you see the agenda of health worker safety staying post-COVID-19? Anyone? Laureen, Dr. Singh?
I don't think it's going away anytime soon. Having lived in Canada through the SARS epidemic, definitely PPE became a front-facing issue that we maybe didn't think about prior to that. And of course, it circles around again as we deal with this current issue. But the problem for the frontline worker is knowing what's the right PPE at the right time, and ensuring that that information is out there so that they're buying into it. Is difficult when you have, government saying one thing, healthcare workers saying another thing, knowing what's the right thing to put in place. And if we aren't united in that conversation, and it's really difficult to get the healthcare worker to be buying in. And additionally, having that concern about whether we're going to have the PPE available is huge. So making sure that our institutions and private practices have that available is huge.
And one additional thing, within EpiNet, as Dr. Singh and Dr. Kamani were also mentioning, we have a module for mucocutaneous exposures. So these are splashes and splatters. And we know from our data from any country that collects it that more than 80% of all of these blood and body fluid exposures are to the face. And the majority of those are to the eyes. And so this goes back to what I was saying earlier, which is going to be so important to keep surveillance going so that we know in 2020 and 2021 that these exposures are decreasing because personal protective equipment use where it's available is increasing. And these eye exposures are extremely high risk because it's not just the transmission of a bloodborne pathogen, but also transmission of an airborne or aerosolized virus like SARS-CoV-2.
But during the COVID situation, the question which you had asked, what we are seeing is there is a numbness to numbers. So the first healthcare worker who was affected, everybody was very sympathetic, they were empathetic, and then they wanted to do everything for that particular healthcare worker. When there were 10, the ratio decreased, and then when there was 100, the whole idea, the whole motivation decreased. We have 1,298 people affected during COVID. There are 392 doctors who have died, and now nobody bothers about it because that is sheer number. So what happens for the first few doesn't happen for the 392th healthcare personnel. So I think that is where the leadership plays a very important role to have the agenda live and really motivate. One of the important things is if the healthcare worker, if they feel that they report and nothing gets done, they don't report because they communicate among themselves. They feel that reporting doesn't have an impact, and so there is no point. So the communication, education, and appropriate feedback to them and to everybody, just not to the worker who has reported, but to everybody, that there is a system in place and there is you can be circled back and there is an effective mechanism is important.
So many things still to discuss, but unfortunately we don't have much time. I would like to just ask each panelist, perhaps 30 seconds, what's your message to our audience, really, to the global health leaders, to the government leaders participating at UNGA this week? What's your message to them on health worker safety? Very, very briefly, please. Amber, maybe you can start.
That's a lot of pressure. I'll stick with surveillance because it's what we do best. And I would say the more information you have about how the injury is occurring, meaning what device is causing the injury and what procedures are causing the injury, the better you can target your resources and target your campaigns to get at preventing those injuries. So targeted interventions are financially responsible, they're fiscally responsible, and they tend to get at the largest measure of prevention in an overall scheme for better public health.
Thank you, Amber. Sanjeev?
Yeah, I think humaneness in medicine practice is important, because I think we cannot be just podium speakers and mentioning about that we care for them. It needs to come in action. I think everybody looks up to the government and they wait for some policy, and that I feel is bad. Every individual, every healthcare worker is responsible, and they need to take up on themselves and create that environment. And I do agree, and I owe a lot to International Patient Safety Center, that surveillance is the key. And thank you very much for having that performer of EpiNet, which we use a lot.
Thank you, Sanjeev. Laureen?
That is a hard question. I think keeping the voice or keeping this idea front facing is really important. Just keeping to plug at this problem, making sure that everybody is aware, because as a healthcare worker, we're aware of our risk, but maybe the rest of the world isn't. So ensuring that that's always out there for people to be aware of and value that the healthcare worker is at risk every day they go into work. So yeah, I think that's about it.
Thank you, Laureen. And Dr. Kimani?
Thank you. I think the world is talking about universal health coverage. This cannot be achieved without healthcare. Healthcare workers need to be protected and remain at work. And therefore, we call upon leaders to invest in improving safety, be they through devices, PPE, training, and everything. Healthcare workers should be as safe as a factory worker or any other worker in the world. Thank you.
Thank you. Thank you so much to our panelists. Thank you for such an enriching discussion. Really learned a lot today. I wanted to just read the second result, the result of our second poll. What is the biggest threat to healthcare workers' safety? 12% said exposure to hazards such as needle sticks and hazardous drugs. 21% said a lack of PPE and safety engineered devices, and 68% actually said a lack of funding for health systems and preparedness. I wanted to turn over back again to my co-moderator, Pete Troilo, to discuss a little bit more about the report before we close in.
Yeah, Jenny, thanks. And thank you for all the panelists. Very interesting discussion. I'm actually going to continue the Q&A that was planned for Karen, and unfortunately she got disconnected, but I would like to introduce Renuka Gade from BD, who is a planned speaker here, and we'll just extend our conversation a little bit, and I'll ask her a few questions. Renuka is the VP for Global Health with BD. She's also on the advisory board for the International Safety Center, and she has a lot of experience leading public-private partnerships in this space. So Renuka, thank you for joining us.
Thank you, Pete. I'm happy to fill in the space, and it's a pity Karen has disconnected, but I think we all shared the same passion, so happy to fill in here.
Absolutely. Well, thanks for stepping in. So in the spirit of UNGA Week, the word partnerships is, as you know, very prevalent during this week. So I just want to ask you, and it was mentioned a little bit in the panel, about the role sort of that donor countries, multilateral organizations like WHO, and private sector companies like BD, and the partnerships among them. What role do they play in this issue, and how have you seen that play out in your own experience?
Okay, and maybe Pete, before I get to that specific question, I might want to just step back and set the context a bit, if that's okay with you.
Sure.
So I joined BD some 23 years ago, 1997, and in the middle of this debate that was described, Gary spoke about how this movement began in the 80s and how the whole community and the world was engaged with HIV being the big hook in terms of the conversation towards healthcare worker safety. And I was living in another part of the world, in Singapore at that point in time. And I have the opportunity to work with Gary, to work with several of the panelists on a personal level on this issue, right? So maybe I came in from the periphery, not when the issue started, but I've been watching this issue for several decades. So you can say this is not so new an issue or topic, and it's known and has been relevant for years. And so why now, and why are we still debating this topic now and in the context of partnerships more so than ever before, right? So I've seen how industry alone can't make an impact. We could come up with, here are the product solutions perhaps that you can use to drive safety. I've seen and witnessed how WHO alone can't drive a sea change. For example, I've been part of the Safe Injection Global Network for WHO for years, and there was progress. There was good progress to say WHO issued some guidelines to say that there has to be a focus on safety engineered devices and programs. But that alone is not enough, because having a guideline is different from having a policy that is effective and mandatory. Then I've seen some countries transition to policies more effectively than others. And even though you may have a policy, it doesn't mean it's enforced. I think it was Sanjeev who used the word, we need to have a mandatory surveillance system. And so there's that little bit of, well, you can have a guideline, you can have a policy, but it's not enforceable. Then I've seen practice with some facilities moving naturally. Doesn't matter the policy, doesn't matter the guidelines, they believe in it, so they move in it. So to me, from witnessing all of this, it became clear that maybe a public-private partnership, back to your question, was the way that you can actually show, case, demonstrate, and take this to the next level. And so one of the things that we did in the space for low middle income countries particularly is looking at the practice of blood drawing. And that again was so well tied into the fact that when you were scaling up for HIV testing, scaling up for getting many more people into the treatment protocol, there was an increased blood draw practice happening, particularly in sub-Saharan Africa, where which is had 75% of the world's HIV burden. And it was at that point in time that I kind of triggered this dialogue with both CDC and the US President's Emergency Plan for AIDS Relief, PEPFAR, to say, while there's so much happening in terms of treatment and access to HIV, perhaps we're not addressing one basic need, which is the quality of sample that's being drawn, and also the threat to the health workers and to the patients, to be honest. If you don't have a good sample in for testing, garbage in is garbage out. It wasn't an easy discussion because funding is spoken for, as you know, in many of these programs, is funding allocated for drugs, for treatment, for diagnostic, for testing. So blood drawing was like me pushing this agenda given what we knew. But then I really have to appreciate these partners because they allowed me to kind of present the problem. And I remember traveling around the world, literally with a flip those days, recording blood drawing practices in different parts of the world to demonstrate my case on why this was a big need. And then it became a really self-propelling movement, so to say, because a partnership was established. Dr. Kimani was key and central to that program when we first started in Kenya. It morphed into many other countries across India as well. And we demonstrated with private sector with CDC at the helm, with the country Ministry of Health coming to play, a practice improvement with surveillance that we actually took from the International Safety Center with Amber to say, here's what it was prior to any intervention, and here what it can be post-intervention. So that kind of a partnership approach was really there to demonstrate what could be done. Now, granted, our partnership was maybe in 10 facilities, high-burden facilities in Kenya, 10 in Zambia, and so on and so forth in every country that we worked in. But what we were doing by doing this public-private partnership, if you will, is to leave behind data points in the country that the country owns, that the country can refer to as their standard, and with due course of funding and policy and progress, they actually could maybe catalyze that movement faster and quicker than if you were just waiting for some government or some action to happen. So I do think demonstrating public-private partnerships or showcasing the actual change and shift in practice is a good practice, good program, so that countries can own it and drive this forward, Pete.
Great. And where do you see this ecosystem going from here? Sort of what's how do we move it forward from here?
So it's again a good question, right? I mean, I think it's an old issue again, not that people are not aware of it. And even if I have to step back, this collaboration with Devex, I mean, I have to say, you guys did a wonderful job shining the light on safety first, looking at this in an impartial manner, bringing in facts to the case, so to say. If I look back, why did we do this with Devex, and what is my expectation on where this can go further, right? Again, as a much younger associated BD, I was presented a book by Dr. Janine Jager, who's not on the panel today, but she was the former head of the International Safety Center and championed the EpiNet surveillance system that Amber has now taken on that torch. She gifted me a book on healthcare worker occupational safety publication. And as I was flipping through those pages, it's a story of every health worker who was injured. And it was very much based on the American health worker stories. That's where I first read Karen's own personal story. And I think that left an impression on me for a long time, and it still continues to. And so when you fast track to today's age with multimedia, with storytelling, and with platforms such as what Devex has to offer, I took that idea, reached out to the Devex team and actually said, how can you make these stories real by actually having a multimedia platform, shining the light on many of these people who were featured in this book, but taking it global? Because you can argue that a lot of progress has been done in the US. You can also argue that much more progress needs to be done. But if you look at the whole world, then a lot more has to happen, period, ex-US, in the global low-middle-income countries, where the issue is there is awareness, but I would maybe to be overstating this, but I would just say there's no action or no sufficient action where we can sit back and say, okay, change is happening. It's not dramatic enough as far as I'm concerned. And so we brought this platform on so that when people share their stories, you're addressing issues of stigma, you're making it real. You're saying, well, if it can happen there, it can happen to me. We're demonstrating cases of how partnerships can drive change. And so where I see it go from here is it should become a movement that is owned by every health worker, whether that's through their nursing association, whether that's through their institution, whether that's through the reference to the WHO standard or country government policy. And I think if you don't take the steering wheel in your own hands, nobody else will. So I'm hoping that programs such as this, not to say that industry will go away or these associations will go away, but I think the coming together of all to empower countries to ask for what is right in the context of UHC, as Dr. Kimani said, in the context of the COVID pandemic, as was discussed, to drive these low-hanging fruits. And the other thing that I didn't refer is, to this invisible threat that people, that Laureen spoke about. We're talking about a very overt needle stick shot in this discussion, but there is this invisible threat of toxic drugs and exposure to chemotherapeutic drugs in the light of the growing trends in cancer, more so in the low middle income countries, I would argue. And before this invisible threat becomes a very visible monster, I think there's an opportunity to kind of move the conversation back to healthcare worker safety. And I also want to say, it doesn't matter whether it's patient safety or healthcare worker safety. Karen said that very well. One doesn't exist without the other, which is why I think we titled our series with Devex simply as safety first. It doesn't matter whether it's patient or healthcare worker, but if that mindset, if that culture of safety is not ingrained, then the battle is lost. And it's already several decades old, and I hope that in my lifetime there will be this sea change in low middle income countries as well.
Those are really inspiring words to close it out, and I think I speak on behalf of Devex to say we've also really gotten a lot out of the partnership, and it's been great working with you. So thanks a lot for your commitment and support. Jenny, thank you, Renuka, very much for those closing comments. Do you have others to?
One more comment, right?
Sure.
I think the issue is personal to me from many fronts. This is where I began my career at BD. This is where I kind of got to know these wonderful panelists, the speakers, the people I worked for, and have seen and witnessed the change. So it's personal. It's also personal to me because if you look at the workforce speed, more than 70% of the workforce, health workforce, particularly nurses, and sometimes it's even a higher number, tend to be women. From a gender diversity perspective, I feel very strong, and it's personal, that women need to be protected, and that we should bring this in from a gender diversity issue as well as from a healthcare worker safety issue. It's also personal because I have my young daughter who's going to join the health workforce. She's going to graduate to become a doctor next year. And, for heroes who are giving their life in the front lines, the least that we can do is keep this conversation alive and work relentlessly to solve the problem. So this is personal, and I really thank, again, Devex and Jenny. I trust as the Global Health Reporter will continue to shine the light on these conversations, not just with this session that we're having on the sidelines of UNGA, but as we go along in the years to come. So thank you again.
Thank you, Renuka. Jenny, I'll pass it back to you.
Thank you so much, Pete, and thank you, Renuka. Absolutely, and you mentioned your daughter is going to be joining the health workforce. Definitely, we at Devex will be, following on from this conversation, not just for the health workers of today, but for the health workers of tomorrow. So thank you very much again for our wonderful set of panelists, for our speakers, for my moderator, co-moderator. I also wanted to just point out, it's unfortunate that we weren't able to get Karen to have a discussion with Karen. Unfortunately, she had a power outage in her area, and we're sorry to have missed her. But thank you again so much to everyone, including the people that have put this together, and also to Jack, our live illustrator, and also very much to our audience for participating and staying with us throughout the end of this event. Just to, I guess. It was a very enlightening discussion, very timely given the situation we're in with COVID-19. And I just want to point out that this is not the end of this discussion. We have a set of events, as we've mentioned early on, throughout this week on UHC, on global health. So please stay tuned and sign up to those events as well.